Okay, Dr. Kong, you can start. Live stream is on.
Thank you. Good afternoon, everyone, and it's such a joy to see everyone on Saturday for the Women and Cardiovascular Disease session organized by the Apcmc. Thank you for inviting me today to speak about the silent threat, unmasking cardiovascular disease in women. I'm Natalie Koh, and I'm a consultant cardiologist at the National Heart Centre in Singapore, with a focus on multimodal cardiac imaging and cardiometabolic disease. As I prepared the deck for today, I had consulted one of my patients, and I thought that her story is very relevant to the subject that we're going to discuss today. She's a 62-year-old woman who was referred from the GP to me last month for ischemic changes on her ECG. She was absolutely asymptomatic. Her ECG showed a normal sinus rhythm with a rate of 68 and T-wave inversions in V1 to V6 that were not dynamic, and there were no serial changes on subsequent ECGs. She had a history of dyslipidemia with an LDL of 4.5 despite being on simvastatin 20 milligrams on night. She also had white coat hypertension. Her father had passed away suddenly at the age of 40 plus, and her mother had IHD diagnosed at the age of 70. Now, we will go back to her case later. Let's talk about why we're all here today. The leading cause of death in women worldwide is cardiovascular disease. 1 in 3 deaths in women are caused by CVD. 13 times as many women die of CVD than of breast cancer. Among important gender differences in CV outcomes, women are more likely to die following a heart attack than men. So it reached the headline sometime in May this year. The American publications picked up on it, popular news picked up on it. And where did this headline, "Women are more than twice as likely to die after a heart attack than men," come from? Well, it came from a European study. This was published by the ESC on the 22nd of May, based off the good work by Dr. Mariana Mationo in Portugal and her team. What she found was that women of all ages who experience a myocardial infarction are at particularly high risk of a poor prognosis. And these women need regular monitoring after their heart event, with strict control of blood pressure, cholesterol levels, and diabetes, and referrals to cardiac rehabilitation. Smoking levels are rising in young women, and these should be tackled along with promoting physical activity and healthy living. What did her study find? This study compared short and long-term outcomes after ST elevation MI in women and men and examined whether any gender differences were apparent in both premenopausal and postmenopausal women. The average age was 62 years in the study and 27% were women. The women in this cohort studied were older than men and had higher rates of hypertension, diabetes, and prior stroke. The key findings from her study showed that the interval between symptoms and treatment with percutaneous coronary intervention did not differ between genders, but in premenopausal women, there was significantly longer treatment delay after arriving at hospital compared to their male peers, 95 versus 80 minutes. Recommended daughter balloon time is actually between 45 to 90 minutes. At 30 days, 11.8% of women had died compared to 4.6% of men, for a hazard ratio of 2.76. At 5 years, nearly 1/3 of women, 32.1%, had died versus 16.9% of men, and more than 1/3 of women experienced MACE within 5 years compared with 19.8% of men. Women were twice as likely than the men to suffer these adverse outcomes after their MI. They had 2 to 3 times higher likelihood than men in the short and long term, even after adjusting for other conditions, despite receiving percutaneous coronary intervention within largely the same time frame as men. Postmenopausal women had worse short and long-term outcomes after MI than men of similar age, and premenopausal women had similar short-term mortality, but poorer prognosis in the long term compared with their male counterparts. There were no differences in the use of medications for goal-directed treatment therapy. And the study did not examine the reasons for these differences. But atypical symptoms of myocardial infarction in women and genetic predisposition were posited to have played a role. So many people responded to these findings, and several expressed disappointment because this study merely reiterated what had been shown in the literature more than 5 to 10 years ago. As recent as 2020, a study published in Circulation studying more than 45,000 first-time heart attack patients found that women had a higher risk than men of dying or developing heart failure in the 5 years after a heart attack. And a 2017 study also found that women had a higher risk of dying in the first year after a heart attack compared to men. So there are specific cardiovascular risk factors for women that the next speaker, Dr. Loh Wan Jia, will be largely discussing, especially when it comes to the hormones in women. And it is important to highlight that traditional risk factors such as dyslipidemia, hypertension, and obesity, while affect both genders, there are some that actually play a bigger role in women than men. Heart disease risk factors for women and specific to women include diabetes. Women with diabetes are more likely to develop heart disease than men with diabetes, and also because diabetes can change the way women feel pain, there is an increased risk of women having silent heart attacks. Emotional stress and depression. Stress and depression affect women's hearts more than men's, and depression may make it difficult to maintain healthy lifestyles and to adhere to therapy that's recommended. Smoking is a greater risk factor for heart disease in women than it is in men. Early menarche, premature menopause, polycystic ovarian syndrome, and hypothalamic amenorrhea are gender-specific cardiovascular risk factors in women, as are pregnancy complications, hypertensive disorders of pregnancy, gestational diabetes, preterm delivery, low or high birth weight fetus are associated with poorer cardiovascular outcomes for women. Oral contraceptives and hormone replacement are also associated with increased cardiovascular risk in the long term. And a family history of early heart disease appears to be a greater risk factor in women than men. Inflammatory diseases like rheumatoid arthritis, lupus, and other inflammatory conditions, often more prevalent in women, may increase the risk of heart disease in both genders. How do we unmask the silence? Women with CVD continue to be underdiagnosed and undertreated due to misconceptions and lack of awareness among both patients and doctors. And regular screening is important to identify CVD early, even in the absence of obvious symptoms. Cue the patient I presented up front. Women can present atypically. What are some atypical symptoms in women? How does their presentation differ from what is commonly reported in the literature? The most common heart attack symptom is, yes, chest pain. But chest pain is not always the most noticeable symptom, especially in women, who are more likely to experience it as a description of pressure or tightness in the chest. They may even have no chest pain at all. And when they have pain, it may actually be more diffuse, spreading to the shoulders, neck, jaw, arms, abdomen, and back. And they may experience pain that feels more like indigestion or heartburn, as well as unexplained anxiety, nausea, dizziness, shortness of breath, palpitations, and cold sweat. And heart attacks in women may even be preceded by unexplained fatigue. Compared with men, women tend to have more symptoms when we are resting, during regular activities, or even asleep. When you look at that list of symptoms, how often have we dismissed this in practice or for ourselves? It reached a point where even the American Heart Association in 2019 published a very helpful infographic to help dispel some of the myths surrounding presentations of heart attacks in women. Women don't always present the same as men, and this infographic, very useful, summarizes the points in the previous slide. What about treatment in women? What are some noted differences in treatment between men and women? In this publication by Mayo Clinic, they found that women are less likely to be treated with aspirin and statins to prevent future heart attacks than are men, despite the fact that studies have shown that benefits are similar in both groups. Women are less likely than men to have coronary artery bypass surgery, perhaps because they have less obstructive disease or smaller arteries with small vessel disease. And cardiac rehabilitation has shown excellent outcomes for patients post myocardial infarction, but women are still less likely to be referred for cardiac rehabilitation than men are. And this is another very helpful infographic on how to prevent heart disease and strokes. And the top lines are to know your risk, to eat a healthy diet, be physically active, watch your BMI, watch your weight, live tobacco-free, manage your conditions with your healthcare team, adhere to your medications, and work with your team, essentially. So these are things that we already know. So I shan't belabor this point. I also want to draw special attention to ischemic heart disease in the pregnant woman. Yesterday, I was visited by one of my patients who is currently 44 years old. She had her first heart attack at 39 years old, 3 months after getting married. She had an LDL of 7 and a very strong family history of MI. Both parents demised at young age from MI. Very likely she has familial hyperlipidemia. Together, we struggled through that first year of adherence and goal-directed medical therapy and dual antiplatelet therapy, reaching a point where we were able to change the prescription to allow her to try IVF. So I was very heartened to see that there were many guidelines actually that recommended the multidisciplinary approach of ischemic heart disease in this high-risk cohort of patients, especially because she is also of advanced maternal age. It is important to recognize that a lot of these women with familial hyperlipidemia are under-recognized on top of the fact that they think, it's an old man smoker's disease. They don't recognize these symptoms. They present late and they have poorer outcomes and they are of reproductive age. They are in the best years of their lives, newlywed, trying to conceive. There is still hope, but it is contingent on stringent management, close surveillance, and high index of suspicion for the diagnosis. Again, another very heartening publication from our American counterparts, a clarion call to reduce the risk and burden of CVD in women, and the fact that we're all here on behalf of the Apcmc as part of efforts to raise awareness, to advocate, and to engage our communities, I think says very much about the progress being made in this field. We look forward to more research emerging in this space to optimize prevention and clinical care specific to women with MI. We look forward to more grants that support the research and also to monitor the progress as we continue to manage our cohorts. Going back to my patient, the 62-year-old asymptomatic woman. What spoke to me was a significant family history and suboptimally controlled dyslipidemia, LDL 4.5. I actually advocated for a more sensitive test because of the pretest probability and ECG findings, despite her lack of symptoms, but she preferred the treadmill echocardiogram because she did not want to have injection medication of contrast. The treadmill echo was unremarkable. However, the stress ECG was positive for ischemia. And given the fact that, she had higher intermediate pretest probability to high, and the discordant findings, despite the fact that she remained asymptomatic, I advised her to consider a more sensitive imaging modality, and she was agreeable then. And this is what the CT coronary angiogram showed. The left anterior descending artery showed a very densely calcified plaque in the mid-LED that rendered assessment of the luminal stenosis a little difficult, challenging. But what was most striking were the non-calcified plaques in the proximal, mid, and distal right coronary artery, severe stenosis across each of these points, which were corroborated on a coronary angiogram. And she subsequently received 3 drug-eluting stents. I just saw her in clinic yesterday, 4 weeks after the first consult. Her LDL is currently 2.2 on atorvastatin 40. We added ezetimibe with a goal to start injectable lipid-lowering therapy if she is not on target. She is also on dual antiplatelets and with a close home monitoring of her blood pressure to ensure that her BP is at target, less than 120/70 per the sprint trial findings, if possible, and asymptomatic. What are some key takeaways from this case that I presented? As clinicians and as patients, we should have a high index of suspicion for cardiovascular disease, even when women are asymptomatic, especially when there are relevant findings. Family history is important, even more so in women. When tests show discordant findings, consider a more sensitive mortality if indicated. reinforce strict adherence to goal-directed therapy with close monitoring to target LDL, A1C, BP, as well as BMI. And I look forward to the speakers ahead as they tackle some of these issues, especially in the advent of digital medicine. Thank you very much for your time.
This is Professor Nusrat from Pakistan. I just want to make a comment. Is it okay? Can you hear me?
Yes, I can.
Yeah, thank you so much. It was a very informative lecture. You covered almost everything. I was just wondering, did you look at the lipoprotein, homocysteine, and CRP? Because in our part of the world, especially the South Asian, I've noticed because I'm very particular about these little things, and there is always gross abnormalities in beta lipoprotein A and B, CRP invariably high, and homocysteine levels are also very high. And if a lady is not willing for any intervention, I've noticed just by giving folic acid, vitamin B12, you can, try to make her life a little more comfortable. Thank you so much. Would you like to comment on that? Thank you.
Oh, Dr. Majid, am I correct?
Yeah.
Those are fantastic points. And in my own practice, I have been testing for lipoprotein little a with much hope on the horizon for therapies to come. And I understand that it is a risk modifier. In many of our patients who have screenings, they come with HSCRP. Lipoprotein little a remains something that is ordered usually by specialists, either the cardiologist or endocrinologist managing dyslipidemia. And routinely, we do not send the apolipoproteins right now in our Singaporean practice. We don't have agreed upon measures in the lab for it. And it is also a matter of cost. In Singapore, we also have access to coronary artery calcium scores that also help, when it comes to risk stratification and for the initiation of therapy with definite CV benefits, such as statins. I hope that answers.
May I?
Thank you. Much obliged. Thank you.
May I?
Yes, hello.
May I? I'm Professor Dr. Sultana Habib. My question is, I may have missed your presentation. Did you inquire on the pregnancy history of this woman?
This woman is 62 years old. She is menopausal. She has completed her family.
Okay, but she did not have any complication during her pregnancy, in her past pregnancy. Did you
No.
inquire in the history?
Yes, I did actually, because her sons attended the clinic with her, because I was highly suspicious of familial hyperlipidemia in her, given the sudden death of her father. So we also took a history of whether she had gestational hypertensive disorders or gestational diabetes. She had none. Her A1C was 4.7%.
Thank you.
My pleasure.
Hello, my name is Wan. I will start off with the second presentation. Let me know if you can't hear me. Okay. So my name is Wan. It's a pleasure to discuss about how female hormones impact cardiovascular health. I'm from Singapore. I'm a consultant endocrinologist. So female hormones affect cardiovascular health in many ways, usually positively, but sometimes less so. Understanding the actions of female hormones is very helpful to also explain some gender-specific risk factors that affects only women. So in men, atherosclerosis tend to occur in the larger vessels and focal obstruction, but in women, there tends to be more of a small vessels disease, more diffuse non-obstructive disease. And there are also other sex differences in terms of cardiovascular disease, but let's just focus on this for a while. It may be because the traditional cardiovascular risk factors already differ in terms of the presentations and severity for an impact on men and women. Women are more likely than men to have prior diagnosis of diabetes, hypertension, CVD, and heart failure, when presenting with the first episode of AMI. Women tend to have a lower prevalence of dyslipidemia and smoking, and the onset of hypertension tend to be later in women than in men because in the pre-menopause state, estrogen has a vasodilatory effect. Smoking and diabetes are more potent risk factors for CVD in women. And women also have specific risk factors, which I'll go through in the next few slides. Of course, apart from hormones and other biological differences, there's also social and cultural factors that could explain why there's a difference between men and women in terms of CVD. So to understand how female hormones affect cardiovascular health, let's look at it at the normal physiological state first, and then also in a dysregulatory or in some conditions. So walk with me through the journey of the female hormones from young to old. So let's talk about estrogen levels. In childhood, that is low and it quickly rises at menarche or puberty. It reaches the peak at the reproductive ages, and there's a very rapid and dramatic decline in menopause transition and remains low at the post-menopause state. Of course, this is an oversimplified diagram of how the female hormones are, because there's also the variation and fluctuations of other hormones such as progesterone, FSH, and LH during menstrual cycles. And in pregnancy, there is a great change of the female hormones and placental hormones. Estrogen itself increases by 30-fold during pregnancy up to childbirth. There's also increase in the stress hormones and growth hormones. So if there were changes in what is considered the normal physiology of female hormones, this could then lead to risk factors for CVD in female. Starting from childhood, an early menarche, so less than 10 years of onset of menarche, has been associated with increased CVD risk when in adulthood. It's not sure why. It could be because there is also some shared risk factors with the girls having early menarche and also having more risk factors for obesity, birth weight, increased birth weight, or certain ethnicity. A late menarche, so it's more than 17 years old, is probably related to the lower estrogen duration that they have in their lifetime. PCOS is a risk factor for diabetes and CVD. This is independent of BMI, and obesity itself will accentuate that risk for diabetes and CVD. OCP, especially in the presence of smoking or hypertension, is a major risk factor for CVD. Infertility, pregnancy-related complications, as well as giving birth 5 or more times have all been recently shown to be risk factors. Not breastfeeding has also been found to be a risk factor for CVD. Conversely, breastfeeding has been shown to be a protective factor. Breast cancer chemoradiotherapy can be cardiotoxic. And menopause, especially premenopause, especially if premature, is also increases the risk of CVD. So probably unknown to most women around the world, pregnancy complications are actually risk factors for the mother. So gestational diabetes increases the risk for lifetime diabetes, but also CVD. More than half of people who have GDM goes on to have type 2 diabetes later on. Preeclampsia, preterm birth, and SGA are all risk factors. This may be because of the underlying metabolic abnormalities, inflammatory processes, and vascular dysfunction. So there's increased insulin resistance, there is dyslipidemia, inflammatory cytokines, endothelial damage, especially the fetal placental unit. This led to short-term and long-term complications in the mother, increased ASCVD risk, and heart failure. The risk also depends on the mother's pre-pregnancy cardiovascular risk factors, hypertension, obesity, diabetes, CKD, her age, her race, her family history, and the genetics. This impact not only the mom and the fetus in the short term, but also has a future generation impact because of the intrauterine programming. So pregnancy losses are also a risk, has been recently shown to be risk factors, such as in this meta-analysis of 22 studies. Over 4 million women were studied, and they looked at the 3 forms of pregnancy losses. So miscarriage increased the risk of coronary heart disease, stillbirth increased the risk of CHD, stroke, and CVD, and induced abortion increased the risk of CVD. So knowing that adverse pregnancy outcomes actually are bad for the mother in the long term. Does this improve the Framingham CV risk score prediction in women? So this study published last year in JAHA showed that there was a decreased survival in terms of 15-20 years for women who had adverse pregnancy outcome. And that adding this to the Framingham risk score did help to reclassify some women a bit more appropriately, more accurately in terms of lifetime risk prediction. So breastfeeding has been shown to be a protective factor. So this is good news for women who have successfully breastfed. They looked at, this study looked at 8 studies of 1 million Paris women published last year, showed that breastfeeding reduced the CVD risk, CHD, and stroke, and fatal CVD roughly by 11%. This is a progressive benefit with a longer duration of breastfeeding. They looked at 0 to 12 months of breastfeeding. The reasons for the protectiveness may be because of a few factors. The main hormones that goes up in breastfeeding would be oxytocin and prolactin. It is probably the oxytocin that has the benefit because it lowers blood pressure. It has anti-diabetic effect and also antioxidant effects. Also because the breastfeeding has been associated with a decreased risk of diabetes and blood pressure, maybe because of resetting of the maternal metabolism. There's also some benefit of inducing weight loss. Looking about menopause and menopause hormonal therapy. So menopause is something that will happen to all women inevitably. It appears that the association with CVD is in the matter of timing of the menopause and HRT. Menopause is a broad term. To be more exact, there are multiple phases. So there's a menopause transition, which is about 2 years, the perimenopause stage, which includes the menopause transition and the first year of the postmenopause. And the postmenopause state can be divided to early and late phase. So the American Heart Association released a scientific statement looking at to talk about menopause transition and its CVD risk. This was in the year 2020, and this statement actually talks about the increase in the metabolic changes such as dyslipidemia, increased LDL ApoB, lower HDL, and increased visceral fat deposition. Estrogen itself, as a HRT, is likely to be cardioprotective. This is for women who are in a premature menopause, so less than 50 years old, but also in women who are in an early menopause, in the 50 to 59 years old, as seen in the Women Health Initiative study. So the estrogen cardioprotection needs to be initiated. For its cardioprotective effect, it has to be before the presence of atherosclerotic plaques, because in animal studies, it showed that they do not remove the formed plaques. HRT is not indicated for cardioprotection alone. It is only for use for vasomotor symptoms and osteoporosis. Let's look at the estrogen molecule. So estrogen molecule endogenously can be E1, E2, E3. The most potent would be E2 estradiol. Estrogen are mostly bound to sex hormone binding globulin, so only 2 to 3% are free and active. Synthetic forms of estrogens are shown here, and then there's a natural form, estradiol E2 here. The synthetic forms on the left here all actually have a slightly different molecular structure, and they have increased adverse events. One of them is actually hypertension. So depending on the dose of the synthetic estrogen, so a high dose of more than 50 micrograms compared to 30 or lower 15, they would have an increased blood pressure effect. The natural ones, estradiol valerate, has a lower blood pressure increasing effect. Progestins, they are now 4th generations, and the 4th generation one, drospirenone, actually in fact have a blood pressure lowering effect. The combined OCP is contraindicated in a few conditions, such as in high risk of ASCVD, uncontrolled hypertension, because the synthetic estrogens can increase the blood pressure up to 7 to 8 millimeter mercury. Valvular heart disorders and people who are likely to have VTE are also contraindications to have OCP. The mechanism of which how estrogens in OCP increases the blood pressure are by a few ways. Firstly, they activate the renin-angiotensin-aldosterone system, and this will cause more salt and water reabsorption. Also, it stimulates the ATH, so more water retention. And thirdly, it increases the sympathetic nervous system, and this also leads to increased blood pressure. So OCP in use in someone who is smoking will increase the risk of heart attack and stroke by 10-fold for heart attack and 3-fold for stroke. And OCP in use in someone with hypertension will increase the risk of CVD by 12-fold. So estrogen, is it the point of, whether it's in a normal state or whether or not if it's additional or whether it's a unusual state? So for example, looking at in a normal state, estrogen is cardioprotective, not and also bone protective, and also for women's general health. In terms of the cardiovascular health, it improves vasculature, it promotes angiogenesis, it promotes vasodilation, it decreases oxidative stress, and improves mitochondrial survival with anti-apoptosis and decreased fibrosis. Having additional estrogen, such as in menopause hormonal therapy, can be cardioprotective when it is given in the early phase, so the 50 to 59 years old. And OCP, depending on the dose and the type, can increase the blood pressure and VTE, and should not be, as people should not smoke, and a contraindication if it's uncontrolled hypertension. I didn't talk much about transgender health. This is an area that needs more research, but I just wanted to point it out that, there's a recent study in Lancet Endocrine 2 years ago, which showed that male to female transition, so a transgender woman, had increased mortality compared to a cisgender woman. And this was looking at 5 decades of adult transgender people receiving hormone treatment in Amsterdam. The reason why they have increased risk of mortality is not clear, but it's probably multifactorial, including the social, cultural, and the dose and the follow in terms of their regular management. So in summary, cardiovascular health is very important in women. CVD risk increases dramatically during the menopause transition, and estrogen in a normal state is a good thing in terms of blood pressure, blood flow, lipids, fat deposition. HRT, OCP have different effects depending on the dose, type, time. And we definitely need larger studies. We need more focused studies on females in terms of sex-specific risk factors, but also in just females in general. And thank you for your time. Thank you for listening.
Yeah, thank you. Am I allowed to make a comment? Can you hear me, Dr. Van? This is Professor Dr. Nusrat from Pakistan. Can you hear me?
Yes, yes.
Yeah, thank you so much. There's no denying the fact about role of hormones in a female's life, but I would tend to differ a bit. You said that hypertension is not very common in premenopausal women. In our part of the world, it's a totally different story. And, very often a 60, 65 years old lady comes for the management of hypertension. And I start inquiring their obstetrical history. They get bugged. Oh, doctor, that was long ago. But when you go dig into that, the usual answer is I have 5 children. During first pregnancy, the pressure went up. During pregnancy, then it became normal. During second pregnancy, again, it went up. And a few weeks to months later, it became normal. And then, I never bothered till, 10 years ago, I fainted and somebody took my pressure. This is one thing. And number two, hormones are important, but I think in female, it is the anatomical and pathophysiological differences that matter more. It is the microcirculation that gets compromised. And number two, because hormones are important, but pathophysiology, the acidoma does not protrude into the lumen, so they do not have typical symptoms. It keeps ulcerating the wall, and the only way to detect that is to do an intravascular ultrasound, which unfortunately is not being practiced, at least in our part of the world. It is only used in operation theater. So, and I think it was one of the myths that younger women do not have ischemic heart disease. If they ever had any such problem, they were dismissed as being cases of broken or bereaved heart. But now, with more and more research, nearly 2 decades from now, people realize that if not all, most of these bereaved hearts were the diseased heart to begin with. Thank you.
Thank you for your comment. I 100% agree with you. Hypertension is a very important risk factor in premenopause state, and also, but it does sometimes becomes worse or actually present itself more in the postmenopause state, maybe for various reasons. It is because the women are more likely to come only after they have more symptoms from menopause, and definitely in our ethnicity, being Asian, we definitely have increased risk of all these metabolic risk factors And I really like your point about the pregnancy-related complications and the preeclampsia, the hypertension, all this, although being short-term and like 9 months, actually really affects women in the long term.
Thank you. Thank you, Dr. Wang. It was a wonderful presentation. Thank you.
Very kind, thank you. Is there any other questions? Or we want to move to the next speaker?
I just want to add one thing. It is in the younger age group, use of OCT should be and should not be advisable to women with POC. Probably you did not mention that. After menopause, it is not it is contraindicated, especially combination hormonal therapy after menopause. But pre-menopause, women with this polycystic ovary, they should not be recommended OCT.
Thank you, Professor Sultana. Okay, that's fantastic. Let's move to the third speaker. Thank you so much.
Hello to all. I'm Dr. Kamal Fatma Amer, and today I hope you all can see my presentation here.
Yes,
Hello?
Kamal, we can. We can see you and your presentation also. What a pleasure to see you early morning. Okay.
Thank you very much, madam. I'm Dr. Kamal Fatma Amer, and I'm working as an associate professor, and I'm an intervention cardiologist working at National Institute of Cardiovascular Diseases, Karachi, Pakistan. And today I'm talking about heart health in the workplace, strategies for women employers and employees. So as my colleagues wonderfully presented heart health in women, I'm just generally talking about this is the number one, cardiovascular disease is the number one disease in all genders across the world. And only in US, it has costed $108.9 billion. So I must say women have their fair share in as far as cardiovascular disease is concerned. And according to American Heart Association, 40 per 100,000 women in US die of heart disease each year. We don't have our own statistics, especially in Asian countries, but it may be higher than that. So heart disease is the number one killer of women. And there are many women who had sudden cardiac death after even no history of cardiac disease, but 94% have at least one coronary heart disease risk factor. So this is imperative that heart researchers investigate women's knowledge and perceive susceptibility of the heart disease risk. This is an article showing epidemiology of cardiovascular disease in Asian women. And this is again a heart problem, which is important in Asian women. There is a high rates of CHD mortality in Indian and Central Asian women. Rates are relatively lower in Southeastern Asians, but Chinese and Indian women have very high rates and mortality from stroke, and they have high prevalence of hypertension, diabetes, obesity. Although obesity and smoking is, of course, less common in Asian population, but it is increasing in younger group. So females, brace yourself with the facts that heart disease is the number one killer of women. So what to do at the workplace? So there should be some wellness programs, and across the world, there are billions of employees, and the workplaces provide a large audience for cardiovascular disease. So it is an important strategy to prevent the major shared risk factors for cardiovascular disease and stroke, and they are smoking, obesity, hypertension, dyslipidemia, physical inactivity, and diabetes. But many of them don't know that. And you know, there are 25 to 30% of companies who have their medical cost per year spent on employees with the major risk factors who are listed above. So healthy employees, healthy organizations, healthy workplace. Employers and employees must be mindful of big and small steps that can add up to a better health. And it is important to think about health at work, given the number of hours we are spending there each week. So there are some matrices which are called employee well-being matrices, where utilization, program uptake, communication and awareness, employee satisfaction, employee turnover, demographics, symptom severity, and time to service, of course. So first of all, the most important thing is prevention. And prevention is always better than cure. I believe, and everybody believe, I hope. So it is the best way to decrease the chances of developing heart disease, and integrating health prevention into the company's culture is an ingredient for increasing company morale, employee retention, overall happiness. And there is a health belief model. I just put this slide to note down the importance of this. This was presented in 1975 and then 1966. And that says that perceptions of susceptibility are a major influence of preventive health behavior. If you know that, you can prevent it. So individuals must perceive themselves to be at risk, especially women, of a health threat before they will take actions to reduce risky behaviors or to engage in healthy alternative behaviors. So, that means assessment of knowledge and perceived susceptibility of heart disease will not necessarily change your client's behavior, but that could help practitioners to tailor programs or interventions to meet women's health promotion, which is needed. This is an infogram of this model. And there are a few examples of modifying factors like age, education, socioeconomics, and knowledge. And that can change the individual beliefs about their susceptibility. And if they perceive the threat, then they can change their behaviors. So, ladies and gentlemen, employees are the pulse of your workforce. They are heartbeat of your company. But how well they are taking care of themselves and how you are taking care of them, that is important. So for employers, especially, cardiovascular health burden can translate to decreased productivity, increased absenteeism, and a spike in workers' compensation claims. So employers' responsibilities are make heart health a part of company culture. Show employees you are invested in their health and well-being by finding ways to help them eat well, maintain a healthy weight, lower stress levels, and quit smoking. Provide them educational materials. Connect with technology if you want to, go for remote and on-site employees all. So why employee benefits are there and why they are important? The first thing is benefit that could help employees, they can go unused. So take time to remind them and do it often. That includes educating employees on the benefits available through their employee assistance program. Encourage routine medical care, routine checkups, send out quarterly health reminders that stress the importance of regular checkups, routine screenings to check blood pressure, cholesterol level, glucose levels, and you can find many more employees who never knew what they had, like high blood pressures and high dyslipidemias and hyperglycemia. And there may be a flex time policy to give employees more option to schedule checkups or make appointments without taking time off from work. Important thing, workouts, work day workouts. Initiate movement at the workplace. Many workers spend, including us, in our hospital settings, we spend long hours in the same position, often at the desk or at the workstation. So encourage your employees to make time for exercise and consider providing movements breakaway from the desk or the workstation, stretching, getting up, moving around. It helps wake the body up and reset the mind. One study found that 20-minute bout of exercise improved focus and decision making for all. So any physical activity is better than none at all. So British Heart Foundation recommends 30 minutes of moderate intensity aerobic activity 5 days a week, while AHA recommends at least 150 minutes per week of moderate intensity aerobic activity or 75 minutes per week of vigorous aerobic activity, or a combination of both, preferably spread throughout the week. So add moderate to high intensity muscle stretching activities such as resistance or weight on at least 2 days per week. Second important point, promote healthy eating in the workplace. What do we eat there? Encourage more vegetables, fruits. You can ask workers to bring in heart-healthy dishes for an office lunch, get together, make it turns to cook nutritious lunches. You can provide healthy snacks at vending machines, but basically what we are providing is sugary drinks and biscuits and chips that are not at all healthy actually. So we can educate and make sure staff are aware of healthy eating campaigns, and is a good place to start. Help employees quit smoking, and that smoking is actually a precursor of many dreadful diseases. Heart disease is not only lung cancers and list of other life-threatening conditions. So try to encourage the smokers to decrease their usage over a period of time while providing support throughout their journey. Women. So already spoke a lot about women. My previous presenters who actually presented and actually given a very, a large amount of women propensity to have cardiovascular disease. Actually, women in workplace, they are very vulnerable and they are looked upon as a vulnerable population as well, because there are so many challenges that have been posed to them by pregnancy, female responsibilities, menopause, and that can heighten cardiovascular diseases. So see that time pressure continues. It represents major challenges for women, men as well, but more in women, to balance their professional life, family life, personal commitments. And a study in 2002 showed 77% of the single mothers were there, just over 60% of married mothers with children under the age of 6 years. So because working mothers and families balance time spent in their personal commitments, job responsibilities, so work policies should incorporate childcare, flexible schedules, elder dependent care as a key feature of workplace health promotion. There was a women's health study. Harvard researchers uncovered strong links between women's job stress and cardiovascular disease. And this was a landmark inquiry into disease prevention involving more than 17,000 female health professionals. And they show that women whose work is highly stressful have a 40% increased risk of heart disease, including heart attacks and the need for bypass, compared with their less stressed colleagues. So as a result, it was presented in 2010, showed that women who worry about losing their jobs are more likely to have high blood pressures and unhealthy cholesterol levels and to be obese. So these findings are especially distressing in the current economic climate. This again, a study, it was done in 2020, published in Scandinavian Journal of Public Health, and showed it was a large 15-year study of nurses in Denmark that concluded that the greater the work pressure, higher the risk for heart disease among women aged 51 and under, and is in a study of white-collar workers in Beijing. Job strain was associated in women, but not in men, with increased thickness of carotid artery wall, an early sign of cardiovascular disease. So job strain is a definite factor. And the researchers have used a definition of job strain that combines psychological demand and degree of control. Psychological demand means amount, pace, and difficulty of work. And degree of control means the ability to make work-related decisions or be creative at work. There are certain coping strategies as well, what females can do to cope with: mutually support relationships with family, friends, co-workers, regular exercise, limit intrusions, practice relaxation techniques, meditation, deep breathing. And if you are feeling overwhelmed, please seek help from a mental health professional. So in institutions, we should make mental health a priority. Offer regular reminders about companies' mental health resources. Provide training, support for supervisors and managers as the first line of contact for mental health related conversations. Encourage one-on-one check-ins with employees. Provide employees with external resources that support mental health. Provide a low stress working environment. create stress management initiatives such as yoga classes. Maybe it has been proven that mental health can directly affect physical health. Flexible work schedules can make much difference for employees, and definitely maybe disadvantages for employers as well. So embrace flexible working schedules. HSC statistics consistently show that stress, depression, anxiety is the leading cause of work-related ill health in the UK. It was in 2020 and 21, it was affecting 822,000 workers. So there are a number of steps employers can take to manage work-related stress. Flexibility is the most cited solution. Introducing more flexible working arrangements and giving employees greater autonomy over how and when they work can help them better manage stressful situations, thereby reducing risk factors like high blood pressures. So this is an interesting slide, which is showing workplace stress index in globally. See that in United States, work-life balance, if you say there were 29% in US and 24% UK, China 16%, and India 30%. And the interesting thing is tension and conflict with the manager. You know, this was 15% in US, 17% in UK, 1%, 17% in India, and 25% in China. Everywhere it is there. So there should be a health model in every institute, every company, and that should have following things like assessment, planning, management, implementation, and evaluation. Thank you very much for listening.
Oh, thank you, Kamal. Oh, no question, just a comment. It was superb. This is one aspect that has never been discussed extensively during our physical as well as virtual meetings. I have to say it was excellent. And I felt as if I was going through my career, how we had to face stresses at different stages of life. And especially in our part of the world, people say that in order to be be something in the society, you have not to be twice, but maybe 10 to 20 times better than a man. So it is so very unfortunate that in this male-dominated society, we all, I'm sure, have been through tremendous stresses to reach the top. Thank you, Kamal. Congratulations. It was lovely.
Thank you very much, Dr. Nusrat. I'm glad we all are here and we are discussing very important topics.
Yeah.
Thank you very much. Moving on to next presenter, if I have no question.
Can I cover?
Yes.
Thank you very much. Kamal, I have, can I ask the other colleagues from Singapore, what you have shown to us is 100% correct. It is the current situation in our institutions. I would like to know from the other colleagues from Singapore, what is there, how do they feel about their situation at workplace? Anyone can answer that from?
Okay, so I work as a consultant endocrinologist in Singapore, and there is lack of awareness about women's health situation. I think that you have rightly summed up, but it's a international problem, and they're very much in Singapore as in an Asian country, which is a very stressful country to work in as well. Yeah, so there's no special thing, but they have hopefully there are a little bit more and more awareness about it. There has been at least some push towards increasing, paternity and some awareness about extending maternity, not in terms of maternity leave for like longer duration, but at least taking at different times when the mom needs it. But generally, I think that there's so much more that can be done for women.
What about how does it work in your institution? You are not a cardiologist. You are not you are endocrinologist probably. Okay, I was actually wanted to talk to a cardiologist, a woman cardiologist, how she has a workplace at her institution. No, it's okay if nobody is here. Kamal, it was a wonderful presentation.
Thank you very much, madam. Thank you very much.
So, I'm Professor Khalid Neuro from Pakistan. I'm the member of Asia Pacific Cardiometabolic Consortium and at present working as interventional cardiologist at Ziauddin University Hospital. The topic of my talk is women's heart health in the digital age, technology and tracking. CVD in women include heart diseases, stroke, peripheral artery disease. A study conducted in Germany from 2017 to 2020 shows that women with chronic heart diseases were decreasing with the comorbid conditions, whereas the incidence of women with no CVD and the other comorbid chronic condition was increasing. Death rate, as told by the other speakers, is more in women due to the CVD than in men. Heart diseases are the #1 killer globally, most likely due to the underdiagnosed and atypical symptoms, hormonal changes due to the gender disparities, age after menopause, guideline on the treatment primarily on the men, and awareness gap in women in most regions of the world. Coming to the definition of sex and gender in relation to the cardiovascular screening, what is the difference? This variability in incidence and death rate could be due to the sex, that is anatomical, physiological, genetic, and low estrogen hormones, which were discussed before also, level in the young woman, as well as multi-dimensional gender differences, like psychological, marital state, low socio-economical level of women, different cultural identities, and role of the social structure in the world. These all factors play a role in cardiovascular disorders and their outcome in the different stages of the woman's life. They need different individualized woman-centered CVD risk factor assessment and screening for the effective management and preventive strategies, especially due to these atypical symptoms, angina in non-obstructive coronaries, and adverse outcome due to the stroke. Coming to today's topic, that is women's heart health in digital age, technology, and tracking, which covers heart health information, sharing, communication with access to internet and smartphones to address the traditional heart challenges in women by access to information, remote monitoring, self-assessment of the data by wearable devices, telemedicine, artificial intelligence, and machine learning algorithms, health and wellness apps for the guidance on nutrition and about the management of stress. Digital tools can synthesize and analyze the sex and gender-specific CVD risk factors and their manifestations in women, help in collection of the health data with machine learning and AI for the analyzing the data. These AI-based algorithms could incorporate data from the activity tracker, digital scales, health, fitness apps to predict women with the risk factors for the CVD, who may benefit from more intensive guideline-based therapy intervention or the cardiac rehabilitation. Modern wearable technologies, which were introduced in 2009 by Fitbit, which owned the category until the Apple Watch were introduced in 2015. But in 21st century, the technology has become integral part of our life and transforming the way we work, communicate, and manage women's heart health by assessing the vital signs, heart rate, tracking, detecting arrhythmias, motivating patients for the lifestyle modifications, and wearing a life-saving defibrillator device. Especially use of the mobile apps empowers women to take control of their heart health in all areas of the fitness. Also guide in medication intake, reduce their long wait time between appointment with the health professionals. Commonly, women are less likely to be diagnosed or treated. So the use of AL and digital tools gives an opportunity to leverage available to improve the CVD care in women, beginning with the screening, so that CVD prevention can be programmed accordingly. AL and ML use in CVD is increasing effectively because of ECG and echo images, for which neural network current ML2 is effective at modeling raw ECG, help in detection of the LV dysfunction, hypertrophic cardiomyopathy, ejection fraction preserved heart failure, cardiac amyloidosis, aortic stenosis, silent ischemia or silent AF from the normal sinus rhythm. Early recognition of the risk factor and CVD have a positive impact on outcomes in young women. Clinical workflow along with the AL tool can help in the diagnosis of channelopathies, familial CMP, congenital heart diseases, and ECG-based deep learning algorithm of AL can diagnose hypertrophic cardiomyopathy in children, diagnosis of the prolonged QR on mobile-based ECG, screening device, digital health support to store data of the ECG, X-ray, genetic test results, medication record, AL-based phonogram for the congenital heart diseases and valvular heart diseases. Yes, for the sending the clinical assessment questionnaire to patient before visit to medical practitioner due to the woman limited time at the clinic visit. Follow-up screening for the gestational diabetes, inflammatory changes in the cervix and uterus to avoid the preterm delivery, and abnormal endothelial function in the pregnancy-induced hypertension should be performed. Use of algorithm to review and interpret by the analysis of blood pressure, weight measurement, to provide education and counsel patients for the value-based care and therapeutic intervention. During the pregnancy and peripartum, potential AL digital tools can be used for the peripartum and postpartum CMP. For remote monitoring of the blood pressure, weight assessment, and transferring the data reliably to the clinical practitioner when in with the ML and smartphone apps can provide educational intervention and prompt science. Potential AL digital tool can be used for the peripartum and postpartum CMP for remote monitoring of the blood pressure, weight assessment, transferring the data reliably to clinical practitioner when incorporated with the ML and smartphone apps, can provide educational intervention and prompt medication compliance. Middle age and menopause during 40 to 75 years. A comprehensive woman-centered approach can be initiated through online patient portal or smartphone application. Linked to the electronic record, especially with My Life Check tool for screening of the risk factors, education on the lifestyle modification, and therapeutic intervention. Women can interact with the practitioner by AL-powered chatbot, electronic patient portals for reduction in the time pressure with the virtual care and monitor devices at the home. Digital tools usually provide opportunities to assess risk factor due to the potential impact of the risk factor screening through the biomarker and imaging for example, breast arterial calcification, which can be seen on routine mammography, have been associated with the risk of death and the CVD outcome. Neural network allow for the automated detection and the quantification of the breast arterial calcification CVD risk screening through this modality. The benefit is huge. In old age, digital health tools can be used to stratify the risk profile of the screening of CVD pathologies like silent atrial fibrillation, undiagnosed left ventricular dysfunction, heart failure with preserved ejection fraction, and for the telehealth reach for the secondary prevention. What is the current use of digital tools and smartphone in the world? Have a look on this issue. A study conducted on USA by Rock Health shows more use in people of the young age group, 18 to 34%. On the second number were middle age group of 40 to 75 years. Use of live video on health medicine and electronic record downloads were high in young age group. With the poor health, people purchase only 8% smartphones, and 53% people purchase as experimentally for this purpose. 42 used to become more physically active, and 35 were interested for the losing weight. 87% wanted to control over the access to the health data, and 77% were interested in sharing data with doctors. Most popular telemedicine source was found to be telephone and the email for doctor-patient communication. In another survey, which was conducted on women to track health-related goals, which were utilizing smartphone to achieve or track health-related goals. 50.3% people to make a health decision in 43.6 regarding the treatment with healthcare provider. Using an electronic wearable device in 33%. Shared health information using electronic monitoring device was least 18.7. Sent are received sent or received SMS text message with the health professional were 35.2%. Scenario is changed in various regions of the world depending on the education level, how to use and get benefit from the heart health tool, especially variable in South Asian countries, according to literacy rate, which is low in Pakistan, and use is lower than the other neighboring countries. Only 40% of the women with gross variability in the use of smartphone in urban with rural areas. 35% in comparison to the 65% in men due to the unaffordable prices of the devices, gender disparities in smartphone ownership, and very low use in the rural area women. So the impact of digital health varies on women with geographical variation, education level, individual motivation, privacy, and security concerns. Despite of offering immense promise for the women heart health, challenges for the implementation of digital health will be due to the privacy concerns, data overload, access to disparities, accuracy, reliability concerns, users' education, Addressing these challenges is vital to maximize the benefit of digital tools in women's heart health. And the security of the medical record may lead to withhold information from the healthcare provider. So transparency is in how data is analyzed and shared is the key point. Unfortunately, women with a specific factor and race, ethnicity, and social determinants are also not included. These factors have impact on the treatment and outcomes, definitely. And compelling example of bias in AL was gender shades study by Joy. She evaluated commercially available facial recognition algorithm and demonstrated that the various systems of the companies were biased with the error as high rate as 35%. In another study, which showed that bias of 31 and 23 in darker skin women. Ale industry unfortunately suffer from the diversity. Only 15 to 10% of the staff at the Facebook and Google is female. So contextual bias in the AL, this could be one of the reasons. However, the future of the digital tools and key trends in the women's heart health is filled with the exciting possibilities, such as genomic medicine, personalized algorithm, assistance on the unique genetics, lifestyle, and health history will offer personalized health recommendations. Virtual reality health will be used for immersive patient education and stress management. Security health data and connected ecosystem will hold the promise of more personalized and accessible solutions. So my conclusion will be that adoption of the various digital tools and data present potential opportunities to expand approach to the CVD in screening and by prevention of the woman-patient communication portals, either facilitating clinical care, providing automated support and reminders through text messaging and systems, educational wellness, smartphone applications, and variety of wearable devices that track physical activity behaviors and biometrics. So the future trends are promising. Advanced wearable, personalized AL and genomic medicines are opening avenues that will redefine how we approach women's heart health. So to empower women and engage her by digital tools, by educating women about their cardiovascular health risks, prevention measures, encouraging her for her active participation in decision making regarding their health, utilizing a digital health technique and wearable devices to monitor and track their progress of the heart. Thank you so much.
Yeah, if there is no other comment, I would like to say another very important but less frequently discussed topic. It was wonderful, but I am afraid that here, besides the efforts of the clinicians or cardiologists, I think we will have to involve policy makers a lot in order to, number one, education is important, and in order to enable these women to connect to their physician and be aware of their heart health. I think these two segments, educationists and policymakers, will play a very important role. Thank you. It was a very good presentation.
So I think any question from the audience?
Khalda, I don't know about, it's like I already know you are working on more on primary care center in rural areas in Pakistan, and that is a very commendable job you are doing there. Use of digital and technology for awareness, I think it should be started first. First, we need to develop a primary care center, a good primary care center in Pakistan. Yes, we have just starting bringing information to the people, and this for primary prevention, use of digital technology will be very helpful in our rural areas where people don't like to come to the clinic, come to the doctor. So it will be very easy for them to, you can think about it like bringing in technology in our rural area, which I know that we are not very well aware in those areas. But in Karachi, most of the people are now taking up digital technology. So I think if you work on the primary care, improving the primary care center in our rural areas, this use of digital technology will go a long way in helping preventing primary, it will be helpful for primary prevention.
But that needs education and how to use this, implement and use these apps and awareness about these apps and their working. So we will have, in comparison to the European countries and developed countries, we are far behind that, and we will take time.
I know it will take time. It will need a lot of hard work from you. Thank you very much.
Thank you. I so
Wonder people are not in mood.
I don't know because chairperson and
Where is the moderator?
organizers are from the Asia Pacific this time.
No,
And
where is the moderator?
they have
Where is
arranged
the,
this
yeah, we heard.
webinar. I don't know.
I think there is nobody from Singapore at the moment.
Or doesn't seem to be.
Hello, Singapore.
They have their management has been changed this week, so that might be the reason.
No, but
Georgia is not available.
there was a lecture from Australia. Where has that gentleman disappeared? The last talk was by a gentleman from Australia.
That was he was the chairperson. He was the chairperson.
So where is he?
So he's not here, but let's put a close to the webinar. Yes, Prof. Khalida? Excellent
Yes.
talk. Yes.
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 So
And
what do you
so-
think? Should we close this webinar?
Yes.
Okay.
Yes, I think it's time to close, and everyone, including the participants and all the speakers, fantastic job.
We want to hear closing comments from you.
Yeah, me? Okay.
Yes.
I want to I honestly I think this was a fantastic idea, Prof. Khalida and everyone who took part in this. And I really thank everyone for their contribution and the comments. I only hope that things get better and better for our future generations, our daughters, our granddaughters, and whether it's digital health, or whether it's in terms of awareness for work balance and the disparities and everything. I think we will all try to work towards a better life for everyone. So thank you and have a wonderful Saturday. So let's close the session.
you.
Okay, bye-bye.
Bye-bye.
Bye-bye. All the best. Thank you. Goodbye.